Thank you so much, Natalie, for that wonderful presentation. Um, I'll say that we very much appreciate you being able to do this recording with us. So I'll be trying to ask questions on behalf of an audience. I'll try to keep it very, very wide. But what I want to start with, you made some really great points, and in your conclusions, you underlined, what's very typical in pregnancy trial research, and then what this feminist critical race framework offers. And so I'll just start with the question of, why do you think that's an important, well, I guess, yeah, why is that a place where we should start? I'm thinking about these systemic interventions and do they, why the hesitancy? Why is it so difficult to implement? Why are we, there's this long list of literature that you're drawing on that talks about these social determinants of health and the social reasons that frame our health and our health outcomes. What's the difficulty in implementing these things, you think, into pregnancy trials?
So I have a response to that in the book in one of my chapters, chapter 2, when I trace this history of maternal health policies with regards to obesity and diabetes and maternal weight and nutrition. And one of the main arcs that I found consistent over the last 50 to 70 years, so I trace back some of these policies from the 1970s, is that individual behaviors and measurements like weight and calorie counts become stable factors for controlling and measuring in clinical trials. So a lot of the psychology, behavioral psychology, and studies around interventions, they rely on having stable variables for measuring and collecting data around. And simply put, people find that collecting weight measurements, collecting calorie counts, collecting foot step counts is manageable data that can be standardized. And so one of the reasons has to do with the methods. The more political reason that is at play here is also in that history, I contextualize this movement and trajectory around measuring maternal health and nutrition with the backdrop of conservative policies disinvesting in public safety nets and healthcare. So what that means is in the United States, there were huge cuts to prenatal care. In the UK, there are also similar cuts that emerged in the aftermath of Thatcherism, and in the United States, Reagan's era also experienced a lot of cuts and kind of a demonizing of the welfare queen, which was a super racist idea and stereotype around how certain people would be taking advantage of healthcare systems and benefit systems in the United States. And similarly, in that rise of what is now understood as neoliberal policies that disinvest into public safety nets and focus on changing individuals and making individuals responsible for their health, this backdrop really influenced the science. And so this is so much a part of why feminist science and technology studies is very important, because we look at the co-production of science and society. And in the case of maternal health policies, the context around conservative policies and economics really shifted the focus to saying, well, we're going to continue to invest in interventions that rely on individual responsibilities, because if we test interventions that are making structural interventions responsible, then that makes the government responsible for managing health. And so in this context, it was a huge shift away from making governments responsible for population health and shifting all of the responsibility to individuals. And that's something that we see currently in the design of these interventions. So that's one methodological and social political reasoning for why we consistently see the focus on individual interventions as opposed to structural interventions. The other issue has to do with the RCT method and how difficult it is to measure effectively structural interventions using an RCT. And so this over-reliance on RCT as a gold standard of evidence-based medicine creates it structures what kinds of research questions we can even ask. And so those are some reasons on the ground for why we see the persistent focus on individuals as opposed to structural interventions.
Thank you. So I think just for some of the people who are listening in to this recording, it perhaps this seems like it calls for an opportunity to reimagine how we start to measure and think about these things in kind of randomized control trials, or maybe other systems of how we can measure and test these kinds of questions. You talk often in your book about race environment. Can you explain a little bit what you mean by that? Yeah.
Yes. So racist environments was an idea that I wanted to develop in the book in order to understand specific forms of racism and experiences of racism. And so I'll actually just read the definition so that I don't confuse my own self. So this was on page 55 of the book, but I define racist environments as a way to frame exposure to racism as both discursive, experiential, material, and visceral. So what this means is that there are ways in which discourses of racism in our language shape forms of discrimination that impact our bodies viscerally and our experiences in the everyday. And it is supposed to think about environmental racism as something that impacts people's everyday lives as well. So it's a concept that's trying to bring together all of the different forms of racism that one could experience, both an instance in an encounter in your everyday life, where you live and how that's subject to toxic chemical pollution, a history of violence that is experienced intergenerationally and transgenerationally. I wanted to bring attention to the ways in which racism has all of these experiential, physical, and discursive realities. And we need to attend to all of them in a complex way, not just thinking one individual experiences racism or thinking about racism as a systemic form. I wanted to bring together these scales of the individual and the systemic in order to think about the context that we live in that impacts our lives, bodies, and experiences and health. And so racist environments was one of the ways that built on the idea of, the ways in which epigenetics is telling us that our environment really impacts our health. Well, if our environment really impacts our health, then we really should be taking seriously racist environments as a variable for our health. In all of these complex ways. It's not just at an individual level or a systemic level. It's not just biological or social. It is a very complex entanglement of racism that I was trying to capture in that concept.
Yeah, thank you very much for that explanation. Because I found that, again, there's finally, a language that brings together all these different ways in which people can experience racism. Here in the UK, at least at the time of recording, this week has been very monumental in the release of 2 reports. So we've got the organization 5 Times More have released a report on Black women's experiences of maternity care, and the charity Birthrights has also released their inquiry on women's experiences, birthing people's experiences, and also of healthcare professional, and it's talking about race, a concept that is just, it's been far too long in the UK. And finally, there's some work that has, focusing on women's experiences in this really big way. And I wanted to ask you, how does your work help us to understand, start to address and dismantle the obstetric racism that we're trying to dismantle in the UK? Do you find that with the, because you talk a lot about the design of trials and the knowledge that we get from these trials, how can this help us with, as we address kind of the racism that we see in maternity care?
That's a great question, and one that better books than my own have been able to address. Specifically, I'm thinking here of Donna Davis's Reproductive Injustice, whose books significantly influenced a measure that is now being used to assess obstetric racism in medical encounters. And so that is a very direct and applied understanding of how to take that lesson to clinical care. And I would say that my book relates to the ways in which we can design our research. And so designing research that is mindful of racism from when you ask the research questions, when you think about the methods, when you think about its implementations, and when you think about who is being targeted. The book is really trying to show and scientists with this material data that asking questions about racism, including pregnant participants into their research at the design table, not afterwards in the implementation stage, is fundamental for creating science and policy and maternal health interventions that are effective. Because ultimately, these interventions are not effective. And if we want to change the effectiveness, we do have to consider these other variables and really fundamentally consider them at the research questions at the design table. And so that's one of the ideas that I'd really like practitioners to take away, to be mindful of how they design their research in a non-hierarchical manner that doesn't undermine expertise. So pregnant people have their own expertise that they can bring to the table. And if we would include that earlier on in our designs of clinical trials, I think we might be seeing very different kinds of interventions, very different kinds of environments that would be targeted for intervention and resources that would be distributed very differently. And so that's something to consider in terms of the ways in which I imagine my book addressing systemic racism and the ways in which science and research plays a role in either perpetuating it or dismantling it.
Yes, thank you so much. This brings me to my next question. So I have to say that I recently had a baby a few months ago. And in my second pregnancy, I experienced gestational diabetes. So I really, your book is fantastic. But one thing that particularly stood out to me is your inclusion of people's narratives, of the participants' narratives. Why was it important for you to include that?
Well, it's important to me because of how I've been trained as a social scientist, ethnographer, feminist ethnographer, anthropologist. And, again, my mentors, one of which is Donna Davis, the focus on individual pregnant people's experiences and particularly Black and Brown women's experiences is really important to drag to the center of reproduction. And this is also drawing on reproductive anthropologists' focus on saying reproduction is an area of theory. And what does it mean to draw both our feminist ethnographic methods and theorizing these spaces? It means taking people's experiences seriously. Those experiences can tell us something about the world around us, and they can create knowledge and theory. And so one of the basic tenets in feminist ethnography is to really, and that's coming out of Black feminism is to take women's experiences, testimonies very seriously as knowledge, as a knowledge base for creating our policies, our theories, our interventions. And so aligned with that methodological and political value, I thought it was really important to include the narratives of pregnant people from their participation in these trials, also because those narratives often get completely left out in the publication of the science. So when we look at results publications of clinical trials, we often never see all of the labor that went into recruiting, all of the labor that went into collecting all of this data, and all of the labor that went into the participants' engagement with the trial and their experiences. And so I really wanted to show people, both who are in the science field and not in the science field, or just pregnant people, that they're not alone in experiencing these things. And this is a very evolving, complicated process that isn't standard, isn't universal. But unfortunately, there are strong themes of discrimination and racism and stratification across race, gender, and class that affect people's the kind of care that they receive and the kind of experiences they have during pregnancy. So one of the main values is that it's based in a Black feminist tradition of listening to people and using their experiences to develop knowledge. And the other real implication of it is that we need to see how the science is made, and we need to listen to people who are participating and receiving these interventions, because I really think that they have a lot of insights to share. I think they have a lot of knowledge to share with scientists in order to create better informed interventions.
Thank you. Thank you so much. That was a beautiful summary. So there's two last points I'll make before we close. Just continue on with the theme of the participants, which is a particular interest of mine. So you talked about Iris's story, and you talked about the labor that she put into when you participating in this trial, with the food and the calories and the steps, and how she had to come back, for these appointments 8 times a month, and the surveillance that put her under. Can you talk a little bit about, or do you have any insights about perhaps what that surveillance, what that experience of that surveillance meant, or potentially could mean? Okay.
Yes,
so, a little visitor, but yes.
It's the question around surveillance, and I think that it's a really good question, one that I started to think about in the last part of the book a little bit more intensely, was around the consequences and the significance of this type of surveillance. So the surveillance happens at multiple scales. At the individual scale, the participants are taught to survey themselves, manage themselves in this very hyper-vigilant way. And like you've also commented, experiencing the amount of monitoring of blood glucose levels, the amount of monitoring of carbs and calories and exercise. It is a lot of self-monitoring, self-surveillance, and on top of that, going into the doctor's offices multiple times a month. I mean, this is a full-time job. Mm-hmm. And so imagining balancing the amount of medical appointments that you have on top of a job, on top of caretaking for other children. I mean, that expectation alone is unbelievable and goes unquestioned. But more importantly, it's the constant assessment and evaluation, and kind of like, it feels like there is somebody always watching you in terms of what you're doing and how you're behaving, and how your behavior should be. If you only did everything perfectly, then your numbers would be great, your levels would be amazing. And all of this illness would just disappear. And that is just a very faulty message to be disseminating to patients and pregnant people under care, is that we know that your individual health and these glucose numbers and screen and kind of managing your metabolism is not under your conscious individual control. No one person has total conscious responsibility and control over the way in which their bodies metabolize and process sugar. It is a very complex science. Diabetes is a very complex science that is, and especially gestational diabetes, is still an area that's not super well understood. And so I think that and we also know from epigenetic literature that we really cannot control 100% independently the ways in which environments impact our metabolism, blood glucose moderating mechanisms, and whatnot. And so I really caution practitioners specifically, and also patients, to advocate to them for themselves, to say, you know, I could do everything perfectly. And we also need to understand that that isn't necessarily going to manifest in, there's no linear association between managing your calories and your screenings completely perfectly and a perfect outcome. And I think that the weight of that assumption is so harmful. And so that is a real consequence of the hypersurveillance, is the message that if you did everything perfectly, you could avoid some kind of health issue. And the reality is that it's much more complicated than that. And so that's one individual repercussion of the hypersurveillance and individual self-surveillance. The other issue is much broader, which has to do with what I theorize in the book as racial surveillance biocapitalism. And what that is this integration of the massive amounts of data collected during pregnancy and the assessment that we could predict or modify future outcomes. And this is very much a part of predictive medicine, a speculative turn in the sciences, that if you just constantly collect more data and survey more data, manage more data, that you could predict anticipate some kind of outcome. And that is really problematic, because there is no linear association. No one can predict the future. And this amount of data collection draws a lot of funding and resources away from public safety nets, and a more harmful consequences that the collaboration or the data sharing policies, specifically in the UK, because in the UK, scientists can add a consent clause in their clinical trials that says they will share all of their data with private collaborators. And with this consent clause, that means that all of the data that is used from your self-surveillance that you submit in your surveys, all of the blood samples that are collected from you during pregnancy and after, all of that data can be used for the production of other products in predictive medicines, like biomarkers that are intended to predict gestational diabetes. But who benefits from that surveillance and the data are not individual present day people, or what are deemed as users of these mechanisms, algorithmic mechanisms, or apps. And so that is a huge challenge and caution around using technologies that survey and manage and collect data at an individual level, promoting this kind of data surveillance and excavation at a large international level. I think that deserves a lot of attention and concern around how that data is used to assess and survey people, and who benefits and who financially benefits specifically off of the collection of that data. So a lot of different levels of surveillance and different kinds of consequences and implications.
Thank you so much, Natali. Just to, I really enjoyed listening to you, and I have a few more questions, but we're out of time. I imagine an audience would still be waiting with lots of questions as well. Can you tell people where they could find your book?
You can find it. I know that it's accessible in the UK at your bookstores. It's also accessible at independent bookstores, online, University of California Press, or even even on Amazon, which if that's the last resort, then then access the book. But you can also ask for your libraries to order it. That would be one way. And if anybody has any questions, please feel free to reach out to me. I'm transitioning institutions. I'll be joining Purdue University in the fall. But if you look up natalievaldez.com, you can find my research and other ways of connecting with me.
Thank you so much, Natali.